Welcome back, everyone, to the Deep Dive. Today, we are going to unpack some really essential knowledge about some of the more, let's say, challenging turns labor and birth can sometimes take.
Yeah, while we all hope for that smooth textbook journey to parenthood, it's so important to be ready for the reality that sometimes complications can crop up.
Totally.
Yeah.
So our goal today is to equip you with a solid understanding of some key complications that can arise and what's really crucial for those involved in supporting the birth process to keep in mind.
Yeah, we've really dug deep into this topic to try and distill that core knowledge around, recognizing when things aren't progressing as expected, what needs to happen to address those issues, and ultimately, striving for that best possible outcome for both the birthing person and their baby.
Absolutely. So whether you're a student nurse getting ready to hit the labor and delivery floor for the first time, or, a faculty member prepping the next generation of healthcare pros, or just someone who's passionate about maternal and newborn health, getting a strong handle on these potential complexities is just so crucial.
Yeah, I think no matter where you are in your journey with this, having a foundation is key.
Right. Okay, so let's jump right in. Let's start with this concept of dystocia, which is essentially when labor takes an unexpected turn.
Right, yeah. So dystocia basically means labor that's not progressing in that typical, normal way that we'd expect.
Got it.
And it's actually, it's more common than you might think. It happens in about 10% of labors.
Oh, wow.
And, it's one of the main reasons why a first-time cesarean birth might become necessary. And unfortunately, it can increase the risk of things like, excessive bleeding after birth, infection, and even the need for interventions like forceps or vacuum during delivery.
Okay, so before we delve into the specific causes of dystocia, can you paint us a quick picture of what we consider to be a normal labor progression?
Sure. So normal labor typically starts with, those regular uterine contractions that gradually increase in their strength and frequency. And these contractions are doing the work, right? They are thinning and opening the cervix. We call that effacement and dilation. And, initially these changes can be pretty slow and subtle, especially in that early labor phase. And then things usually start to pick up pace when the cervix reaches about 5 to 6 centimeters dilated. That's generally considered the active phase of labor. And it's during this active phase, that we might start to see signs that labor is not moving along as smoothly as we'd anticipated.
And that's when we might hear terms like failure to progress.
Yeah,
right?
Exactly. Because every labor is so individual and we can't always predict the exact pace right at the start, healthcare providers often use that phrase, failure to progress, to kind of describe a situation where either the cervix isn't dilating as quickly as we'd expect, or the baby's head isn't moving down through the pelvis as it should, or, sometimes both.
Right.
But it's important to remember that a diagnosis of dystocia usually comes, after we've had a chance to observe labor for a reasonable amount of time, what we call an adequate trial of labor.
Gotcha. And there are, quite a few factors, according to the information we've been looking at, that can increase the risk of dystocia, right?
Yeah, there are a lot, actually. And it really goes to show just how complex and interconnected all of these factors are that influence the whole labor process.
Verbally.
So some of these things include, having an epidural for pain management, which can sometimes affect the intensity of contractions. Or, if a birthing person receives a lot of pain medication, that can also play a role.
Makes sense.
Carrying twins or more, having an excess of amniotic fluid, a condition called hydramnios, and even something as simple as the birthing person becoming really exhausted, those can all contribute. And then we have, things like if the baby's position isn't ideal, like if they are in what we call an occiput posterior position where the back of their head is against the birthing person's back, that can slow things down because a slightly larger part of the baby's head is trying to pass through the pelvis.
Right.
If the baby's head isn't well flexed or tucked down, that can also be an issue.
Oh, interesting.
And then, a longer than average early stage of labor, being a first-time parent, even things like maternal height less than 5 feet tall can be associated with an increased risk of dystocia.
Wow, it's fascinating how many factors there are.
It really is. And then there's the baby size. A baby weighing over 8.8 pounds, a history of shoulder dystocia, if the baby is presenting in a way other than head down like breech, and even certain developmental variations in the baby can all play a role.
Wow, so many things to consider.
Right. And then even maternal age over 34, higher caffeine intake, being overweight, a pregnancy lasting beyond 41 weeks, a uterine infection called chorioamnionitis, weaker uterine contractions, and even if the baby's head is still high in the pelvis when the cervix is fully dilated, all those things can be linked to a greater chance of dystocia.
And is it true that labor might be progressing differently today compared to, like, decades ago?
Yeah, that's a really important point. Research is actually showing that labor might be a bit slower now compared to what was like historically considered normal. And there are a few thoughts about why that might be. Things like higher average body mass indexes among pregnant individuals, rising rates of labor induction, and the more frequent use of epidurals for pain relief.
Interesting.
Yeah, it's something that even, organizations like the World Health Organization are emphasizing that, those higher rates of surgical births don't always mean better outcomes and can even increase the risk of complications.
Right. And it seems like even the timing of when someone is admitted to the hospital during labor can have an effect.
Absolutely. Admitting someone to the hospital too early in labor, especially during that initial, less active latent phase, might actually lead to like an increase in the diagnosis of dystocia.
Really?
Yeah. And that then can increase the likelihood of interventions like augmentation or epidurals, which could potentially up the chances of ending up with a surgical birth. So the information we've reviewed really stresses that in those early stages, sometimes taking a more conservative approach is really beneficial.
So, like, what would that look like?
So, ensuring good hydration, encouraging rest, providing that emotional and physical support, and maybe even considering some mild sedation if needed. Sometimes patience is really the best tool, just letting labor kind of establish its own natural rhythm.
I love that. So when we talk about dystocia, what are, like, the main categories of underlying issues that can actually cause it?
So we can generally group the causes of dystocia into four main areas. Problems with the powers, which refers to the effectiveness of those uterine contractions and the pushing efforts. Problems with the passenger, which includes the baby's size, position, presentation, and any developmental variations. Challenges with the passageway, which is talking about the bony pelvis and the soft tissues of the birth canal. And then finally, the psyche, the emotional and psychological state of the birthing person, like stress, anxiety, those kinds of things.
Okay, those make sense. So let's start with those powers. What kinds of issues can happen with contractions themselves?
Right. So when the uterus isn't contracting effectively, we typically see a couple of main patterns. One is called hypertonic uterine dysfunction.
Yeah.
Basically, the uterus doesn't relax completely between contractions.
Okay.
And those contractions tend to be like uncoordinated, erratic, often kind of just localized to one part of the uterus. They can be super painful and exhausting for the birthing person, but they don't actually lead to much progress in dilating the cervix or helping the baby descend. This pattern is more common in first-time moms during that early labor, and it can sometimes impact the baby's oxygen supply.
Oh, wow.
And then on the flip side, we have hypotonic uterine dysfunction. This usually happens during active labor, and it's when the contractions become weak, infrequent, and they just lack that intensity needed to keep dilating the cervix.
Got it.
And this can be associated with things like, an overstretched uterus, maybe because of a large baby, multiple babies, or excess amniotic fluid. Also, having had multiple previous pregnancies, a full bladder, or even, too much pain medication can play a role.
Makes sense.
And one of the big concerns with hypotonic contractions is an increased risk of postpartum hemorrhage because the uterus might not contract strongly enough after delivery to control that bleeding.
Okay, that makes sense. Now, the information we've reviewed also mentions protracted and arrest disorders. What exactly do those mean?
So instead of just saying abnormal labor, we can also classify labor progress based on the rate of change. So protracted means a labor that's moving slower than what we typically expect.
Okay.
So this includes things like protracted active phase dilation, where the cervix is opening up slower than average, and protracted descent, where the baby's head is moving down slowly. Sometimes the slow progress might be because of, the baby's size or position in relation to the pelvis.
I see.
But often, simply making sure the birthing person is well hydrated, has eaten, and is feeling emotionally supported, and encouraging them to try different positions can make a difference in helping labor move along.
Got it.
Then we have arrest disorders, and this is where things have basically stopped completely.
Oh.
So this can be secondary arrest of dilation, where there's no more cervical change for over 2 hours.
Okay.
Arrest of descent, where the baby's head doesn't move down for more than an hour in a first-time mom, or 30 minutes in someone who's given birth before, and then complete failure of descent.
And I'm guessing labor can also be like super fast.
Oh, yeah, absolutely. We call that precipitate labor. And that's when the whole process from start to finish is done in less than 3 hours.
Wow, 3 hours.
Yeah. And, while a fast labor might sound great on paper, it can actually carry some increased risks. For the birthing person, there's a greater chance of, tears in the cervix, tears in the perineum, and in rare cases, even uterine rupture if the cervix doesn't have enough time to dilate fully.
Oh, I see.
And for the baby, there's that potential risk of head trauma, like bleeding in the skull and hypoxia because everything is happening so fast. It can also just be really overwhelming and intense for the birthing person, both physically and emotionally.
Right. Yeah, that makes sense. So shifting gears a bit, let's talk about those passenger issues that can lead to dystocia.
Yeah, so anyway, the baby is positioned in the uterus that isn't that ideal head down, facing the mother's front position, which is called occiput anterior, or even slight variations in their position can make dystocia more likely. So one common thing is when the baby is in what we call a persistent occiput posterior position. That's where the back of the baby's head is against the birthing person's back. And that can slow down the descent because a larger part of the head is trying to come through first.
Got it.
And then breech presentation, that's where the baby's bottom or feet are coming out first. That's another factor that can lead to dystocia. While sometimes a procedure called an external cephalic version, or ECV, can be tried to try and turn the baby, nowadays a cesarean birth is often recommended for breech presentations just for safety reasons.
Right. That makes sense. And then we have the issues of size, especially shoulder dystocia and macrosomia. Can you explain those a little bit?
Yes, absolutely. So shoulder dystocia is a situation where the baby's head has been born, but the shoulders get stuck behind the mother's pubic bone.
Oh, wow.
And it's considered an obstetric emergency because the baby's airway can be compressed and they need to be born quickly. It's thought that shoulder dystocia is becoming more common, maybe because of the rising average birth weights we're seeing.
Interesting.
It poses risks to both the birthing person and the baby. For the birthing person, there's an increased risk of postpartum hemorrhage, tearing, and even, rarely, uterine rupture. For the baby, the most common injuries are brachial plexus palsies, which affect the nerves that control the arm and hand, and fractures of the clavicle or humerus. Prompt recognition and maneuvers like the McRoberts maneuver and suprapubic pressure are really key to resolving shoulder dystocia quickly and safely.
And what about macrosomia?
So macrosomia is when a baby is born weighing over 4,000 grams, or about 8 pounds, 13 ounces. And larger babies can just make labor longer and more difficult. There's also that increased risk of shoulder dystocia and a higher chance of postpartum hemorrhage for the birthing person. And babies born with macrosomia are also at a higher risk of, developing obesity, diabetes, and cardiovascular disease later in life. So in those cases where a large baby is suspected, healthcare providers might discuss the option of a planned cesarean birth with the family.
Okay, that makes sense. What about the passageway? What things about the birthing person's anatomy can make labor tougher?
So problems with the passageway can be, with the bony structure of the pelvis itself. There can be a narrowing at the pelvic inlet, which is the top opening, the mid-pelvis, or the pelvic outlet, which is the bottom opening.
Okay.
And a narrowing in the mid-pelvis is actually more common and often what stops the baby's head from coming down.
Got it.
Then you can also have soft tissue dystocia, where it's not the bones, but the soft tissues that are causing the problem. So this might be swelling of the cervix, the vagina, or even a full bladder getting in the way.
That makes sense. And lastly, we have the psyche. How can the birthing person's mental and emotional state have an impact on labor?
This is huge. A birthing person's emotional experience during labor is so powerful. Feelings like fear, anxiety, feeling helpless or isolated, those can all lead to a lot of stress.
Absolutely.
And stress can trigger the release of hormones that can actually mess with the normal contractions of the uterus, making them less coordinated or less effective.
Wow.
Anxiety can also make pain feel worse, make muscles tense up, and that can also make it harder for the uterus to work efficiently.
Right. Okay, so considering all these potential issues, what are some key assessments that a nurse needs to be doing when caring for someone experiencing dystocia?
So it starts with a good, thorough history, looking for any risk factors, things like height, weight, previous pregnancies and how they went, the baby's estimated size and position, even the emotional state of the birthing person and their support system.
Right.
And then during labor, constantly assessing their emotional well-being is key. Watching for any signs of fear, anxiety, stress, or if they're not feeling supported.
Thanks.
We've got to monitor those vital signs: temperature, heart rate, blood pressure, looking for any signs of infection or dehydration.
Oh, yeah.
Evaluating those uterine contractions is so important. How often are they coming? How strong are they? How long do they last? And are there any changes from what we were seeing before?
Mm-hmm.
Continuous electronic fetal monitoring is a must, so we can pick up on any signs of fetal distress.
Right.
And then we've got Leopold maneuvers, which are those abdominal palpations we do to figure out the baby's position and see if there are any malpresentations.
Right.
And of course, vaginal exams to check cervical dilation and effacement, how far down the baby's head is in the pelvis, that's called station.
Yeah.
And to see if the membranes have ruptured, and if so, what the amniotic fluid looks like.
Okay, that's a lot to keep track of. So what does management look like when dystocia is happening?
Honestly, sometimes the biggest thing is patience.
I can see that.
Really, the nurse's primary role is to provide that ongoing physical and emotional support to the birthing person and whoever is supporting them. Throughout labor, we've got to be closely watching their fluid balance, making sure they're not getting dehydrated, and that they're able to empty their bladder regularly. You'd be surprised how a full bladder can get in the way of the baby's descent.
Really?
Oh, yeah. And then we're always monitoring the baby's well-being, too, especially watching out for umbilical cord prolapse, if the baby is breech or if the water breaks before the head is well engaged in the pelvis.
Okay, that makes sense.
And then we've got to be ready to give meds, like oxytocin if the doctor orders it, to try to strengthen those contractions. And we need to be able to assist with maneuvers if shoulder dystocia happens.
Right.
We also have to keep the birthing person and their family informed, make sure they understand what's going on and are prepared for the possibility of a cesarean if things aren't progressing safely.
Makes sense.
And then there are things we can do to try and help the baby rotate to a better position, like counter pressure and back rubs, especially if the baby is occiput posterior. Different positions can help too. And things like visualization can be great for relaxation and coping.
Mm-hmm.
We're always assessing their pain level, how much distress they're in, how tired they are, and giving pain meds as needed, and just really being there for them emotionally, letting them know they're doing a great job, and keeping them updated on how things are progressing. All of that is so important.
It sounds like such a crucial role for the nurse.
Yeah.
Okay, let's shift gears now and talk about preterm labor.
Okay, yeah. So preterm labor is when we see regular contractions along with the cervix thinning or opening before 37 weeks of pregnancy.
Got it.
And if this keeps going, it leads to preterm birth, which is unfortunately a major cause of illness and death in babies. In the U.S., about 1 in 10 babies are born prematurely, and this rate is even higher for African American birthing people.
And I imagine the consequences of a baby being born too early can be pretty serious.
Oh, definitely. It's a huge contributor to developmental delays, health problems, even behavioral and social issues later on. It accounts for a big chunk of all newborn illnesses and deaths. Premature babies can have all sorts of complications: breathing problems, infections, heart defects, trouble regulating their temperature, bleeding in the brain, jaundice, low blood sugar, feeding difficulties, neurological problems.
Wow.
It's a lot. And many of these little ones end up facing lifelong disabilities like cerebral palsy, intellectual disabilities, vision, or hearing loss. But there is some good news.
Okay, go.
Giving corticosteroids to the birthing person before a preterm birth, ideally between 24 and 34 weeks, can significantly help the baby's lungs mature and improve their overall outcomes.
Yeah, it's great.
It is. But even with all the advancements we've made in neonatal care, prematurity is still the leading cause of death in the first month of life, and the second leading cause of all infant deaths. And so often, we don't know exactly why preterm labor happens, which is why prevention is so important.
So how do we usually manage preterm labor from a medical standpoint?
So there's not one magic bullet medication that stops preterm labor. And the research on different treatments is kind of all over the place, honestly.
Oh, I see.
Yeah, so the decision about whether or not to intervene and what to use really depends on a lot of things, like how likely is it that labor is going to keep going, how far along is the pregnancy, what are the risks and benefits of different options for both the mother and the baby. Mm-hmm. And current guidelines generally advise against trying to push the pregnancy to a full 39 weeks if there's a medical reason for delivering earlier.
Right.
Now, there are some things that do seem to help prevent preterm birth in certain situations. Things like consistent care from the same midwife or team throughout pregnancy, screening for infections in people under 37 weeks who aren't showing signs of labor, watching out for any bleeding, and zinc supplements for people without other health problems.
Okay.
But interestingly enough, the research doesn't really support the routine use of things like cervical pessaries, which are those devices that are inserted into the vagina, or checking everyone's cervical length, or giving vaginal vaginal progesterone to everybody.
That's interesting.
It is. And then antibiotics, they don't really seem to help prolong pregnancy when someone's in preterm labor. So they should be used mainly to prevent group B strep infection if birth seems like it's going to happen soon.
Gotcha.
Now, sometimes we use medications called tocolytics to try to delay birth for a little bit, usually for a few days, maybe up to a week. This gives us time to give those corticosteroids to help the baby's lungs mature and to arrange for a transfer to a hospital that has an NICU if needed. And usually we consider tocolytics before 34 weeks with the goal of giving the baby more time to develop and reducing the severity of breathing problems if they do come early. They don't always stop labor completely, but they can often buy us valuable time.
Right.
But there are times when tocolytics aren't recommended. Things like placental abruption if the baby is in distress or has died, if there's not enough amniotic fluid, severe preeclampsia, active bleeding, if the cervix is already dilated more than 6 centimeters, if there's a uterine infection, or if the birthing person isn't stable medically.
Makes sense.
And remember, those corticosteroids are so vital in helping the baby's lungs develop. They work best when given between 24 and 34 weeks. And they usually need at least a day to really take effect. So timing is everything.
It sounds like it.
Yeah.
So what are the most important nursing assessments for someone who might be in preterm labor?
Early recognition, that's really the name of the game. But it can be tricky because those early signs can be so subtle and easily missed.
Right.
Getting a detailed history is so important, figuring out if there are any risk factors. And nurses have to be super tuned in even to those little complaints that might seem kind of vague. Things like a change in vaginal discharge, maybe it's more mucousy, watery, or even a little bloody.
Okay.
Feeling pressure in the pelvis, a low backache, cramps that feel like period cramps, any signs of a UTI, just feeling full or heavy in the pelvis, upset stomach, just not feeling quite right, achiness in the thighs, or any contractions, even if they don't hurt.
Wow. It's amazing how subtle some of those signs can be.
It really is. We need to be paying attention to how often those contractions are happening, how long they're lasting. Like if there are more than 6 an hour or 4 every 20 minutes or 8 in an hour and they're not going away, that's something we need to look into. And then we'll do a vaginal exam to see how dilated and effaced the cervix is, how far down the baby is, and all that.
Right.
There are some lab tests that might be ordered too, like a CBC to check for infection, a urinalysis to rule out a UTI, and sometimes an amniotic fluid analysis if the water has broken.
Gotcha.
And then there are some other tests that can help us figure out how likely it is that someone will deliver prematurely, like a fetal fibronectin test, and measuring the length of the cervix using ultrasound.
Okay. Can you explain those a little more?
Sure. So fetal fibronectin is this protein that if it's found in the vaginal secretions between 22 and 34 weeks, it can mean there's a higher risk of the water breaking soon. But things like having sex or a recent cervical exam can affect the accuracy of this test. A negative test is actually really reassuring. It means preterm labor is probably unlikely in the next couple of weeks.
That's good to know.
It is. And then we can measure the length of the cervix with an ultrasound, usually between 16 and 24 Wirtz. A longer cervix is usually a good sign, while a short one can mean a higher risk of preterm birth. But remember, all of these tests are just pieces of the puzzle. They're most helpful when we look at them, along with the whole clinical picture.
That makes a lot of sense. So how does nursing care address the challenges of preterm labor?
So again, early detection is really the key to improving outcomes. But because preterm labor can be caused by so many things and people might not recognize the symptoms right away, it can be really tough.
Right.
But regardless of whether we can get those contractions to stop, good supportive nursing care is absolutely essential. That means keeping a close eye on vital signs, tracking fluid intake and output, encouraging bed rest, usually lying on the left side to help blood flow to the uterus and placenta, continuous fetal monitoring to check on the baby, limiting vaginal exams to reduce the risk of infection, and watching out for any side effects from tocolytics if we're using them.
Okay.
And we've got to be communicating clearly, consistently, explaining what's happening, why we're doing what we're doing, and what the plan is. That helps to calm everyone down and build trust.
Absolutely.
Now, if we do start tocolytic therapy, the main goals are to try to stop or at least delay labor for a couple of days. This gives us time to give those corticosteroids to mature the baby's lungs and to get the mother transferred to a hospital with the NICU if that's needed.
I see.
We usually need a solid diagnosis of preterm labor before starting tocolytics. That means both regular contractions and changes in the cervix. And it's important to try to figure out what might be causing the preterm labor in the first place. And like we said before, there are times when tocolytics aren't safe to use. Bed rest and drinking lots of fluids are often recommended. But honestly, the research isn't very clear on whether those actually work to stop preterm labor.
Interesting.
So prevention is really the best approach. Things like helping people quit smoking and using substances, making sure they have access to good nutrition and are gaining weight appropriately, recommending good spacing between pregnancies, maybe using progesterone supplements in certain high-risk cases, a cervical cerclage that's a stitch in the cervix for people with a short cervix, treating infections quickly, and helping to reduce stress.
Right. So many things we can do to try and prevent it in the first place.
Exactly. And then we have specific tocolytics like magnesium sulfate, indomethacin, nifedipine, and betamethasone, which is a corticosteroid. And each of these has its own way of working, its own potential side effects, and nursing considerations. So monitoring is really important. Education is huge, too. We need to be teaching the birthing person and their family about those risk factors for preterm labor, what the symptoms are, what to do if they think they might be in labor, the importance of prenatal care, all of that.
That makes sense.
And then emotional support, assessing stress levels, emphasizing the need for close follow-up, encouraging them to talk to their doctor, acknowledging how challenging this whole experience can be. All of that is so important.
It really is. So much of nursing is about supporting the emotional side of things.
Absolutely,
Yeah.
especially in a situation like this.
Okay, let's move on to pregnancies that go past their due date. What are the implications of a post-term pregnancy?
So post-term is when a pregnancy goes beyond 42 weeks. That's 294 days or more from the first day of the last period. This happens in about 10% of pregnancies. But it's important to remember that a lot of times the due date might not be accurate.
Right, that makes sense. And I imagine there can be more risks involved when a pregnancy goes post-term.
Yes, unfortunately. For the birthing person, the baby is more likely to be larger, which can increase the chance of needing a cesarean. There's also a higher risk of dystocia, birth injuries, postpartum hemorrhage, and infection. And things like forceps, vacuum, or induction might be needed. Plus, there's the physical and emotional exhaustion that comes with waiting so long.
I can only imagine.
Yeah, it's tough. For the baby, there's a higher risk of macrosomia, shoulder dystocia, and brachial plexus injuries, which are those nerve injuries in the arm. They might have lower APGAR scores, and there's the risk of post-maturity syndrome, where they might have lost some of that protective fat layer and have meconium staining.
Wow.
Then there's the possibility of cephalopelvic disproportion, where the baby's head is too big for the pelvis, and problems with the placenta, which can lead to not enough amniotic fluid and an increased risk of cord compression and hypoxia. And then hypoxia can lead to meconium aspiration, where the baby inhales meconium into their lungs.
So many potential complications.
It's a lot, and it's why we monitor post-term pregnancy so closely.
So what are the main things you focus on when assessing and managing a post-term pregnancy?
The first thing is to double-check the due date and make sure it's as accurate as possible. And then close monitoring of the baby's well-being is key. That usually involves things like kick counts, non-stress tests, biophysical profiles, and checking the amount of amniotic fluid.
Okay.
And we also want to understand how the birthing person is feeling about all of this. Do they understand what the tests are for? How are they handling the stress and anxiety of waiting? What kind of support do they have? All of that is important.
It sounds like it.
When it comes to management, the big decision is whether to induce labor or wait and see if it starts naturally. This is something that's often discussed with the birthing person and their provider, taking into account their preferences and all the factors involved. If we're waiting, that close monitoring is crucial. And if we're inducing, we provide a ton of emotional support. Having a post-term pregnancy can be very anxiety-provoking, especially with all the extra tests and interventions. So we give them space to talk about their feelings, reassure them based on the baby's test results, and educate them about everything that's going on.
That makes a lot of sense.
And then during labor, continuous fetal monitoring is a must to catch any signs of distress early on. We watch their hydration closely to make sure there's good blood flow to the placenta. When their water breaks, we check the amniotic fluid carefully, looking at the color, amount, and odor, and report any meconium staining right away. And we keep a close eye on the contractions because dysfunctional labor is more common in post-term pregnancies. And of course, we're providing that constant support, answering questions, and encouraging them through it all.
So many important nursing considerations. Now let's talk about labor induction and augmentation.
Okay, yeah. So ideally, labor would just start on its own when the baby's ready, but sometimes we need to help things along a bit. Induction is when we start labor artificially, and augmentation is when we're helping to strengthen contractions once labor has already begun.
Got it.
Now, the rate of induction has really gone up in the U.S., and there's a lot of evidence showing that elective induction, especially for first-time moms, can increase the risk of cesarean, longer labors, needing forceps or vacuum, having an epidural, and even the baby needing to go to the NICU.
Wow, that's a lot to consider.
It is.